This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1198, recorded on March 7, 2025. I'm Vincent Racaniello. You're listening to the podcast all about viruses. Joining me today from Thailand, Daniel Griffin.
Hello, everyone. I'm coming to you from the future, Vincent. Here it is the 8th. It's 5:15 a.m.
Wow. Back to the
Yes,
future. Nothing on your
exactly.
tie, Daniel.
Well, actually, I did this specially for you because I've gone into the past. So for you, it's still Friday,
It
right?
is.
So
It is.
so this is my, since we're recording on a Friday, this is my sexually transmitted infection bow tie. It's the clap, right? You were asking me what are my two favorite bow ties when I travel. So this is for everybody, back there in New York on Friday. But once I finish recording, then I will switch over to my other favorite, my coronavirus bow tie.
Coronavirus. All right. What
Because
is
I'm
it? It's morning there now, right?
so it's a little after 5 in the morning, actually 5:10 in the morning, but I was so anxious. I couldn't wait to record this. And I'm here at a virology conference, and I was in Malaysia, Kuching, Malaysia, then I was in Kuala Lumpur, and now I'm at a conference here in Bangkok, and then I will be back to New York.
I hear the food in Thailand is really good. Do you agree?
That is true. That is true. Yeah. It's a little spicy, so I have to be a little careful. I usually think I can eat spicy food, and then this is a good reality check for me.
Okay. Careful.
All right. Well, we got a lot to cover, right? And I will tell everyone ahead of time, lots on measles. So we'll start off with hello, everyone. I'm going to give you a quotation, and then think about who might have said this. Love of liberty means the guarding of every resource that makes freedom possible, from the sanctity of our families and the wealth of our soil to the genius of our scientists. And that was Ike. That was Dwight D. Eisenhower.
Who was a Republican, by the way.
But wasn't he a little like on the socialist side? Wasn't he like trying to provide care for like elderly people? And, So, yeah. All right, things have changed. But all right, we've got a number of topics. A little bit first on Ebola. It was too good to be true is how I'll theme this section. And we read in the WHO Weekly Health Emergency Update that a 4-year-old male child resident of Kampala, Uganda. Kampala is the capital, right? You fly into Entebbe. You may remember that movie, 7 Days in Entebbe. And then Kampala is this huge, sprawling city that, if you can, you try to drive past to in the wee hours of the morning or middle of the night because it's just traffic is crazy. It's a sprawling city. So Kampala, big sprawling city, the child was taken to a number of health facilities, finally referred to a 4th health facility in Kampala, admitted, child ended up dying, and was buried. His death was confirmed to be due to Sudan Ebola virus. Concerning is this report that his mother and her baby, so younger sibling, had also just died. Now, it goes on. We actually heard just yesterday in New York time, Thursday, that a new cluster of 3 more confirmed and 2 probable cases have been detected. So, and actually these, I didn't mention, but these are in a couple other districts. The original had been in 3 districts. So, we're not sure that the Ebola thing is under control. And maybe a little bit of bad news. We read in a nice piece by Apoorva Mandavili that the Trump administration has canceled at least 4 of the 5 contracts with organizations that helped manage this outbreak in Uganda. So the terminated USAID contracts funded Ebola screening at Ugandan airports. It's a little bit worrisome, right? Protective equipment for health workers, really trying to prevent transmission of this disease. And we're hearing about this actually, apparently, spreading this anonymously because people are afraid that if they actually go on the record, that this has happened, there might be some form of retaliation. So at the airport in Entebbe, Uganda, screening was on pause for more than 2 weeks because of this freeze. And then they decided to resume the work, but using their own funds, but then the contract was terminated. So not sure exactly what's happening there. Not good,
Daniel,
Vincent.
The Supreme Court said he's got to give the money to them. It's not his to stop. Did you hear that?
So I did hear that, but I guess what we're hearing is that there still is all this fear of retaliation. So even though theoretically the money should be going forward, people are afraid of taking that money, doing these things, and then later there being retaliation. So yeah, you know what, Vincent? I have decided when you mix science and politics, you get disease.
Yeah, that's a good one. I like that.
So, all right, polio. Last week, over 600,000 more doses of the novel oral poliovirus 2 was given to children under 10 years of age in Gaza. We keep going back to this issue about what are we doing every time we give folks oral poliovirus. We have this reversion. We're basically putting virus back into the shall we call it the ecosystem, the environment. So I'm going to leave in a link to an article people can spend some time on, global withdrawal of Sabin oral poliovirus type 2 vaccine in 2016. And just to read a little bit, because we've got a lot to talk about with measles, but we read the continued vaccine-associated paralytic poliomyelitis, VAP burden, around 200 to 400 cases each year. So these are little kids getting paralyzed, was becoming more unacceptable following wild poliovirus 2 eradication. And circulating vaccine-derived polioviruses, typically emerging and spreading in populations with no immunity, posed a threat to reestablishing poliovirus transmission. Basically shedding a virus now and then is reestablishing reservoirs. And I think we've suggested, as they do in this article, it's really not ethical to continue with the oral poliovirus type 2. Any comments there, Vincent, before we move on?
Yeah, it's a good article we briefly discussed on TWiV, where they really point out that now the WHO wants to phase out OPV 1 and 3. And it's going to have the same issue because there's still circulating virus and there are going to be outbreaks if they do that. So it's a real issue.
Yeah, it's a little troubling. And this is we'll be talking about a little bit about misinformation here. But I was having dinner with a colleague of mine, a physician. And apparently the misinformation on the other side, he was saying, so just because I want to get this straight, does polio actually make people paralyzed, or was it something else that was going on? I was like, oh my gosh. So there is this idea out there that it wasn't the poliovirus. Poliovirus was just around. It was really bad hygiene and other things. Yeah. So just, poliovirus makes you paralyzed.
Yes, this is thanks to RFK Jr., who believes in miasma.
Yes, which is scary. But okay, measles. All right, so we've got a lot here on measles. Consider this sort of our measles-focused episode. We get updates from Texas, but we're also going to need to follow updates from New Mexico, as you'll hear in a minute. So Texas is telling us, their Health and Human Services, that we're up to 198 cases since late January, 23 individuals in the hospital. We've clarified they're not in there for quarantine. They do not hospitalize people for quarantine. They're in there because these are little children having struggling to breathe. We also read, and I think it's sort of a nice headline, Texas measles outbreak doubles over 2 weeks. A second person with measles died, but the official cause of death hasn't been determined. And they note that, in the South Plains region of Texas, up to 198, but then another 30 cases across the border in New Mexico. And that's where we get this report of second death reported in growing measles outbreak. And so this is an adult, a New Mexico adult who actually died unvaccinated. And this person did not go for medical attention, so they're still trying to clarify what happened, but they did test positive for measles. So that's the concern at this point. So, fortunately or unfortunately, however, we're going to sort of spin this or take this. There was a headline, Kennedy Jr. backtracks and says U.S. measles outbreak is now a top priority for health department. And so here we read in this article, I'll leave a link from The Guardian, 2 days after initially downplaying the outbreak as not unusual, the U.S. Health Secretary, Robert F. Kennedy Jr., said he recognizes the serious impact of the ongoing measles epidemic in Texas, which one person had died at this point, and said the government is providing resources, including protective vaccines. Kennedy and his Federal Department of Health and Human Services would send Texas 2,000 doses of measles, mumps, and rubella vaccine. And
but
how
Daniel,
did this go over with his folks, Vincent?
Not well. Not well.
No, it did not go. But what were you going to say, Vincent?
But he's also sending vitamin A and cod liver oil. What's that all about, Daniel?
Okay, so we're going to have to talk about that. So first, let's talk about the fact that this did not go over with this crowd, right? Because you can't spend, decades of your life telling people that measles is not a thing, saying that really is just big pharma hype to sort of, keep you down. And then, you end up with a child dying and he now sort of has to spin around and say, okay, remember I said that vaccine was poison? Now I'm going to tell you that that's not actually true. I've been lying to you. So nice article, RFK Jr. sparks anti-vaxxer anger, quote unquote, no different than Fauci. And they quote a tweet, RFK Jr. is already proving to be a fraud and no different than Fauci or anyone else from the old regime. Here he is encouraging the MMR vaccine, which is one of the most dangerous vaccines in the market and causes inflammation of the brain. What a shame. Total letdown. So, all right. So nobody's happy with RFK Jr. I'm not sure he's happy with himself, but I was going to spend this to give a little primer on measles. We'll talk about, the little bit of the history, figuring out what was causing this disease, a little bit about vaccines, and then we're going to talk about the role of cod liver oil, lack thereof, the role of vitamin A, and also the lack of a role of antibiotics in a viral disease. So sit back. This is going to be exciting. You can always fast forward if you don't, want this deep dive, but here it is. First, the disease. So 1757, a Scottish doctor, so hats off to the Scots, Francis Home, discovered that measles was caused by a pathogen. How did he do this? You ready for this? He transmitted the disease to healthy individuals using the blood of infected patients. Right, so he draws the blood from folks with measles, and then he injects it into people, and then they get measles. I'm not sure that would get past an IRB today, right?
No, but you could do this in those days, yeah.
Yeah, apparently that was okay back then. So, once you get exposed, it could take 10 to 14 days. After exposure, there's a bit of a gap. And then we call it the four Ds, the 4-day fever. And then this is, you get cough, coryza, and conjunctivitis. And then comes the rash, right? So you get sick first. The rash isn't there right away. These little Koplik spots in your mouth are there before you end up with that rash. So sometimes you don't know. And this rash, we say it's characteristic. Probably people recognized it when it was more common, but it starts behind the ears, a bit of the face, and then it starts to spread, eventually sort of joining it. So sort of small patches, then they become these large patches. Now, in developed countries, this is actually an important point. We actually started to see a drop in mortality before the vaccines, and completely honest, part of this is better nutrition, but the really big timing issue, and I don't want people to miss this, is the discovery of antibiotics, right? And we'll talk a little disease. So you get sick initially, you've got the viral phase, and then you have that post-viral where people end up starting to get these secondary bacterial infections. And our ability to step in with antibiotics, really, if you look at that, was sort of the timing. So this drop was pretty significant, but it still left us with thousands of children being hospitalized each year, hundreds of children dying each year. And then this issue we've talked about, once you get measles, it basically wipes slate, this immune amnesia. So now in the next 2 to 5 years, you still have more kids dying from things that they should have had immunity to. So this is 1 in 1,000 children dying acutely, 1 in 1,000 children getting brain swelling, encephalitis, lots of ear infections, right? Lots of deafness, croup, diarrhea, pneumonia. So hygiene, dry hair, and good character, and antibiotics only get you so far. So let's move on to a little bit more about this. So globally, despite this, you still had mortality rates remaining high. Millions of cases, over 2 million deaths a year. And then in the US, we're talking about all these cases. We're talking about 300 to 500 deaths per year. And I think RFK Jr. does this math as well. Instead of 1 in 1,000, he says 1 in 1,250, but still comes out to 300 to 500 kids dying each year. So people start thinking about a vaccine, and they start thinking about, well, what do we know about back then? So as far back as the 1700s, when they realized that if you inject one person to another, you can get them sick, they start saying, well, why don't I go ahead and take some of these samples of blood or secretions from the upper respiratory tract, and I will do scarification, right? Sort of thinking of like the early, the smallpox vaccine. Let's take a little bit of stuff from the pustule and, what they say is expose people in an unnatural route. So maybe the virus doesn't do well and the immune system can get educated. So they do this mobilization. Doesn't work particularly well. So then they move on in the 1900s to start trying attenuated or inactivated virus. And they're really not doing well until the 1950s. That brings us to an outbreak at a boarding school just outside of Boston, Massachusetts. And here there's an outbreak at one of these boarding schools. And they send this child, his name will become famous, but Dr. Thomas Pebbles obtains a sample from this 11-year-old schoolboy, David Edmonston, and they actually are able to cultivate the virus from this boy. So you've got John Enders, you've got Dr. Thomas Pebbles. They're isolating the virus and they're starting to culture it in cells. They start passaging it through cells. And they start doing some monkey experiments once they passed it through a bunch of cells and it has become attenuated, less virulent. And then they move on to the first clinical trial. I'm going to mention a few of these trials because one of the issues that the anti-vaxxers throw at us is they say, oh, none of the vaccines you're using right now have been placebo-controlled trials, right? They want us to take kids like in Texas right now where there's 200 cases and half of them get saline injected and half of them don't. So I'm going to cringe a little as I go through this because their first clinical trial, and you'll see several, is they start in a state school for mentally deficient children. So 13 children. And they go ahead and 11 of them get this subcutaneous vaccine. The remaining 2 were similarly inoculated, but they're controls. And for they're just using the tissue culture medium, apparently not saline. That's a little upsetting to folks. But they actually see that this is rather well tolerated, but now they're waiting around for that natural experiment. Is there going to be an outbreak? There never is. So that's sort of the first one. So then they move on, and now they're going to do more. And again, where do they go? To another state home and training school out in Colorado, pediatric wards at National Jewish Hospital. And in the state home, there's about 800 children with mental or physical disabilities. The patients at National Jewish Hospital are, otherwise healthy, except for tuberculosis, asthma, or other chronic respiratory diseases. And they find a number of susceptible children. They try out their vaccine. Again, they get some safety and some serology data, but we still don't know if it works yet. Another trial trying to figure out what's the best way to administer this. And again, where are they doing this? They're going to another one of these institutions. They try injecting the vaccine. They try putting it in the kids' eyes. They try squirting it up their noses. We still don't know if it's going to work yet. But now we finally move on to our efficacy study. And I'm going to leave links to all this for a deep dive for folks. Here, they vaccinate a group of institutionalized and home-dwelling children in Cleveland, Ohio. There were 10 documented household exposures to measles among the vaccinated children during this 5-month period, and none of the people who are vaccinated have any symptoms of measles. So small study, but no control group, 100% protection. So now they get pretty excited. Now we get a controlled trial. And again, vulnerable institutionalized children. Study was conducted at Willowbrook State School, Institution for Children with Intellectual Disabilities, Staten Island, New York. February 8th, 1960, a group of 46 presumably susceptible children were identified. Their parents signed consents to be included. The measles vaccine was administered to 23 children subcutaneously, not in the eyes or up the nose. The remaining 23 were not inoculated, so there are control. And then in January 1960, big measles outbreak in New York City. We start to see cases. During the next 2 weeks, huge outbreak. And basically, we're seeing all 23 vaccinated children were solidly protected. About 60% of the other children end up acquiring measles. And unfortunately, in the unvaccinated children, not only did they see disease, but there were at least 4 deaths. So now they move on to some healthy children living at home, 39 children, 26 families. They get the vaccine subcutaneously, 33 unvaccinated sibling service controls. And again, they follow these kids, and we see clear-cut clinical measles develop in 7 of the unvaccinated children in 6 different families. No cases of measles in the vaccinated children. So really impressive stuff. And I'll leave a link. There's a really nice, it's an 8-article series in New England Journal of Medicine. And we read, in 1958, the last year for which complete statistics are available, 552 deaths in the United States were attributed to measles. In the same year, 255 deaths were caused by poliomyelitis. And so, Vincent, I'm thinking of the mainstream media article, measles is bad, comparing it to polio is worse. So,
indeed.
So I'll leave a link. There's a number of trials that go on. And in 1963, we get the first licensed measles vaccines. And this is where it's important because docs were getting a lot of questions. What should I do? What's going on with the vaccines? Do I need a booster? Well, in 1963, the first licensed vaccines, and there's 2 of them, right? So the first 2 measles vaccines were initially licensed in the US, and both contained this David Edvinston B measles strain, isolated by John Enders and Thomas Pebbles. We have Rubiovax. This is an attenuated vaccine manufactured by Merck. And here's where we get into a little trouble. Pfizer gets approval for a formalin inactivated virus vaccine. The Rubiovax vaccine is reported to be 95% effective at preventing measles. But in the next few years, we get a whole bunch of different licensed measles vaccine. And a bunch of them are this inactivated approach, and they're really not so effective. So for a memory trip, think in the early days, inactivated equals ineffective, right? So the attenuated, that works. The inactivated don't work. So in 1968, like what is that date we keep talking about? This is where there's an updated version of the measles vaccine. Dr. Maurice Hilleman passed the virus through chick embryo cells 40 times, ends up with a much better vaccine. It does not produce the severe side effects we were seeing from the initial attenuated vaccine. And this is the Edmonston-Enders strain. And all the modern vaccines are based upon this. So going forward, we're basically going to move forward just with attenuated vaccines based on the Edmonston-Enders strain. They should have called it the Hilleman strain. So here's the take-home message for clinicians. Measles was so widespread before 1957 that if you were born before 1957, everyone pretty much got measles, so you're considered to already be immune, so we don't need to vaccinate you. But then remember, we have this weird window. So if you received the measles vaccine in the 1960s, particularly prior to 1968, that little window, we're not really sure what vaccine you might have gotten, right? So if we're not sure, you might have gotten one of those inactivated or ineffective vaccines. So we say, go ahead, you've actually got to get one of these proper inactivated vaccines. So before 57, you're good to go. If you get a vaccine in the 60s, prior to 1968, you might not have gotten a great vaccine. So the recommendation is to go ahead. Okay. And then we move into, I'm really going to say the monitor, 1971. Hilleman again introduces the MMR, the measles, mumps, rubella vaccine. You get an initial shot, you get a booster. So MMR is 2 shots. If you only got 1 shot, you need a second. If you don't know, you can always check titers or just go ahead and get that second shot. But here's what is a stickler for the anti-vaccine folks. As the time went by, you sort of saw all these studies. All the currently approved vaccines are based upon non-inferiority seroresponse rates, SRR trials. We followed them over time. We continue to see effectiveness. But also a little bit of a challenge that we're going to run into is we give the first shot at 12 to 15 months of age, the second shot at 4 to 6 years of age. But unfortunately, we just had a couple of cases of measles in New York City, Vincent. And one of the two was an infant under the age of 1. And because they're too young, they had not reached the age where we vaccinate yet. People might ask, what's going on? Why don't we start vaccinating younger, maybe 6 months, because we do that for people traveling to high-risk areas. That is being studied because, if measles is back to stay, those younger vulnerable kids may need a 6 month and then get into the 1 year, 4 to 6 years. Yeah, it's estimated, this is a really nice thing, measles vaccination has probably prevented more than 60 million deaths worldwide in 2000 to 2023, so in the first 2 decades of this century. All right, what about treatment, Vincent? Let's talk about vitamin A. We'll start there. Ouch. So yeah, there is some evidence for vitamin A, but I want to point out, and I'll leave in some links here, is that all the evidence we have for vitamin A, and it's a sort of an age-based dosage of vitamin A, and it's a dose on the day of diagnosis. It's another dose. It's 2 days because the 1 day never showed efficacy. But these 2 days in limited resource settings where there are malnutrition and vitamin A deficiency situations, there may be some benefit. We're not really sure if this does much at all, in a place like the U.S. where children are probably not vitamin A deficient. So what do we do when the kids are initially diagnosed? Sure, it's fine to give the vitamin A, but don't put too much stock in that. Some of the kids will progress. They'll require oxygen, supportive care, right? We talked about almost 24 in the hospital already. And then timing. If they progress to develop a bacterial infection, there might be a role for antibiotics. But let's talk about some of the bad advice out there. Texas doctors have seen very, very good results, Mr. Kennedy claimed, by treating measles cases with a steroid, right? What do we know about giving steroids to people trying to fight off a viral infection? Not a good idea. An antibiotic. What are people doing, right? I mean, these people don't even want vaccines, and now you're disrupting the microbiome of their poor child with clarithromycin. Another bit of bad advice. Cod liver oil. I don't know where that's coming from. And then he also said high levels of vitamin A and vitamin D. So we talked about the vitamin A, but no evidence to support cod liver oil, no evidence to support ivermectin or steroids, no antibiotics, actually potentially harmful unless we're in that secondary bacterial phase, and all the harms we come from giving people steroids. So, if you have a sick child with measles, get your advice from a pediatrician, not social media or a political appointee or a lawyer for that matter. And please, no measles parties. There's a much safer option, the vaccine.
So, Daniel, the vitamin A does not prevent you from getting measles. It's just, what? You should get vaccinated, right? Vitamin A is useless.
Yeah, so in limited resource settings, so I've treated patients with measles in Uganda, for instance. There are some studies, and there's a nice Cochrane review, and this is Cochrane, the science reviews, not the guy who defended OJ, where they actually show in those settings you can have a mortality benefit for treatment with vitamin A. We're not really sure it does much in the U.S. in this setting, and it certainly doesn't protect you from measles. No data out there showing that. What protects you from getting measles is this safe and effective vaccine, and it's a shame. There are some really upset people out there, really concerned about the vaccine, because people have just lied to them. People just made stuff up for their own personal profit. RFK Jr. among them, and now he's having to backtrack. Maybe, I don't know if he's being forced from somewhere or if he actually has a conscience. But yeah, it's people are upset. They're upset about this vaccine, and it's because people lied to them.
So earlier you mentioned an article, a tweet, I think, by an anti-vax person who said measles vaccine causes brain inflammation. Is that another lie?
So that is a lie. Now we've always been completely clear about the fact that vaccines, I think Paul Offito says it's a biologically active product. So there can be side effects, right? So there's a certain percent of children that will have seizures. It's like 2 per some, 10 or 20,000 will actually have a seizure because they'll have a fever, much safer than getting measles and, death. And some people will have reactions. They might even get a mild rash. Because remember, this is an attenuated virus. So there can be some side effects to the vaccine. But much safer, as we see. I mean, the measles virus is still circulating. We have over 100,000 deaths worldwide. It's clearly back here in this country, and now people are dying. So, and all that autism stuff, particularly people worried about like giving their dogs, autism with the rabies shot. This does not. That was actually people lying to you for their personal benefit, and that lie is out there. All right. And I'm not going to give us an update on bird flu this week because we did so much on, so it must all be better, but we'll circle back to that next week. Okay, influenza levels are still high, but we're actually moving in the right direction, I hope, right? We already had that little second tick, but, we're not seeing a huge reduction, but we do seem to be going down a little bit. So, encouraging data there. And I've got added a new graphic, and this is this nice emergency department visits in the US. And you could see it's starting to come down for COVID, starting to come down quite a bit for flu, really coming down for RSV. So RSV levels still high, but moving in the right direction. And we will move on to COVID, which is coming down. We're down now in sort of this medium era. Unfortunately, we did have a few states where the mortality went up a little bit. So was that Michigan, even the Upper Peninsula, Pennsylvania, a few other states where we're still having some pretty high. But fortunately, we've got our multicolored wastewater trend, and it really looks like we're going down across the board.
Yep, it does.
But you know what's amazing? When I look at this, our summer peak was higher than our winter peak.
That's really weird. Yeah.
Yeah. What a weird virus.
Weird. I wonder if we'll have a summer peak. I wonder if we'll have a summer peak next year. Let's find out. This year,
I'm hoping it kind of trickles down. Like we get a peak, but it's not as high and kind of on forward. I mean, I like the wastewater because in much of the world, people just don't test, right? And I was joking at one of my talks that if you don't do a test, it'll never be positive, right? So, yeah.
Yep.
All right. And I just put in this week, I don't know if people are quite as, shall I say, obsessed with SARS-CoV-2 variants. Remember when people are obsessed? That's the reason why we have 2 peaks a year, because there's a variant. There's always a new variant.
Yeah. Yep.
So, So XEC is being pushed out by this LP81, so people can remember that if they want. This might have been relevant when people were talking about vaccine selection, but not sure what's going to happen there for the moment. But yeah, vaccines, hammering on this. We get the MMWR interim estimates of the 2024-2025 COVID-19 vaccine efficacy among adults aged greater than 18. Vision and IV networks, September through January. So that's our September 2024 through January 2025. Was it helpful to get those boosts? And here we read that the vaccine effectiveness was 33% against ER visits or urgent care visits among adults, and 45 to 46% against hospitalization among adults aged 65 and over. So really some good data, right? I know we're down to only about 18% of people get these boosts, but you're seeing, particularly for folks over 65, about a 50% reduction in ending up in the hospital if you get that booster. And across the board, a 33% reduction in ED visits and urgent care visits. So.
Did they say which vaccines they're looking at here, or?
So these are mostly it's interesting. These are mostly the mRNA vaccines, right? People are still mostly going with the Pfizer and the Moderna. It's really interesting. I mean, Novavax has a marketing issue. So for all the people who are all upset about mRNA vaccines, there's a traditional protein-based approach to Novavax as well. But, might serve us as a people to get a little more attention on that as an option if you don't want to use one of the mRNA approaches.
Do you believe that the efficacy, say, against hospitalization and severe disease is any different, mRNA versus Novavax?
All the data suggests about the same. Yeah.
Okay.
Okay. And COVID, early viral phase. I don't think we're seeing any big changes here. Still, the big workhorse in the U.S. is Paxlovid. That's going to be over 90% of the oral antiviral use in the U.S. Still, a little bit of remdesivir that we're seeing. And remember that Paxlovid, going to see, depending on your study, we have hundreds of studies now, over 700 studies showing, not only the initial randomized control trial, but a lot of real world evidence that we can reduce the risk of progression. Remdesivir, a little bit of a hard lift. We still have a few percent of folks being treated with that option. Molnupiravir is really like no other options, and sort of the same with convalescent plasma. The early inflammatory, that's that week 2, right? That's when you start to get better, and then you get hit with that inflammatory phase. That's when people actually start to feel pretty rotten. Remember, treatment that first week is going to reduce the severity, not the incidence of those second week symptoms. Steroids, anticoagulation, pulmonary support. And what about remdesivir, right? We still have a window, and we got another article, the effect of early and delayed treatment with remdesivir on mortality in patients hospitalized with COVID-19, published in Open Forum Infectious Disease. And here they use electronic health records in the National COVID Cohort Collaborative Database. They identified 373,226 eligible person trial hospitalizations, of which 53,959 were initiators, like started on remdesivir, versus 319,267 who were not started on remdesivir treatment. And they divided them into clinical severity based upon the baseline oxygenation. So you've got people who are not on supplemental oxygen, people who are non-invasive supplemental, people who are invasive ventilation, right, intubated. And the trials, they're looking at people that were started 1 to 3 days and days 4 to 7 of hospitalization. And they found that if you jump in so early but not delayed, remdesivir treatment was associated with a reduction in 60-day mortality in the no supplemental oxygen group, and the non-invasive oxygen group, but not if you wait, and not if people end up already on a ventilator. And I'm going to close this out there, Vincent, by saying, as I've been saying for a while, and maybe this whole measles issue is reminding people, no one is safe until everyone is safe. Diseases know no borders. And I do want everyone to pause here. Right now I'm in Thailand. I'll be back in the US for a few days before I head down to Panama to meet the team of floating doctors. We're right now in the middle of our floating doctors fundraiser for February, March, and April. We'll double those donations up to a maximum donation of $20,000.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Susan writes, I'm writing because an over 70-year-old friend sent me a Time magazine article referring to a Canadian study in JAMA, which says Paxlovid didn't prevent hospitalizations or death in older people. My friend is now thinking this proves, or at least casts serious doubt on whether there's any reason to take Paxlovid if he gets COVID. But doesn't this result fly in the face of findings of many other studies? The JAMA paper only references Pfizer clinical trial data, which it says was with a younger population. But aren't there other studies showing the effectiveness of Paxlovid in other individuals? I thought this was well established, so I'm confused. What's your take on the JAMA study and Time's reporting of it?
I think you got to realize, like, if they published a study, yes, Paxlovid works, no one's going to read it. So there's always this selection bias, right? As I mentioned, we have hundreds and hundreds of real world evidence trials showing in different populations, in different contexts, the effectiveness here. There's been a little bit of a challenge, the number needed to treat, right? Early on, we had 20% of folks ending up in the hospital. A 90% reduction was huge. When you had, a case fatality rate of 5%, 90% reduction was huge. So as those numbers go down, the number needed to treat goes up. The absolute reduction goes down, but still lots and lots of studies. And this is the challenge. You say, I've got 1,000 studies, or say, but what about this one? So what about this outlier? Sure. So that's going to be a challenge, but no, it's a very well established. And as we just pointed out again. Particularly in the high-risk person, whatever that baseline risk is, you're seeing a 50 to 90% reduction in all these different outcomes.
Vincent writes, what are your thoughts of adding an H5N1 strain to the current yearly flu shots? Is that something we can do?
That's really interesting, actually. I like this question. Is it getting to that point where we need to be thinking about this, right? Because there's always this huge lead time, right? Like we're thinking now about what's going to go into people's arms in October, so how many months from now? Like 8 months from now. So right now, I don't think we're thinking that this makes any sense, but what's going to be going on 8 months from now? So we'll need to keep an eye on this. I don't think right now when they meet, this is going to be part of the discussion, but we'll have to see what happens.
All right, Mario repeats what you've already addressed, but it's not a bad idea to say it again. Dr. Griffin, can you comment on the effectiveness or lack thereof of vitamin A treatment against measles? And he posts the statement, which is on the HHS website by RFK Jr., that studies have found vitamin A can dramatically reduce measles mortality.
Yeah, so we covered this a little, but yeah, great to rehash it. So there are a number of studies that were conducted mostly in sub-Saharan Africa, so mostly in areas limited resources, lots of vitamin A deficiencies, and in those contexts, a 2-day treatment with vitamin A was shown to reduce mortality. It's about 25% reduction, so real reduction, and a nice Cochrane review looking at that as well. But we're not sure it does anything here in the U.S., but no trials ever showing that this does much in the U.S. in our population. And it really is, here you've got a vaccine close to 100% efficacious, particularly close to 100% at preventing children from dying of measles, versus a vitamin supplement that may or may not provide any benefit.
And Amy writes, I've heard that a few people have contracted bird flu from backyard birds. Is it wise not to use bird feeders or bird baths?
So, Amy, here I am in Asia, and they're making fun of us because our solution to our egg shortage is everyone in the U.S. is going to start having, backyard hens. And I'm sure they're only making fun of us, in a warm, loving manner. Maybe not. But the interesting issue, right? We had duck yesterday, which I was saying is quite a treat because all the ducks in Long Island are now dead. The domesticated duck breeder, fortunately, the whole operation was wiped out, but the migrating ducks seem to somehow tolerate this better. We still haven't seen a major issue with this crossover. So I'm not sure I'm ready to tell people to stop feeding the birds or get rid of those bird baths.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Thank you. And everyone, be safe.